Mute. Okay. Secretary, you are able to hear me and see me clearly?
Yes, sir. Yes, sir.
Oh, perfect. Thank you so much for confirming, Shivang. That's really nice and kind of you. And with folded hands, apologies to our esteemed speaker and to all the panelists and attendees for the delay on my part. I'm so sorry. Dr. Jain, very good evening.
Good evening. How are you?
I'm good. I'm perfectly fine, Dr. Jain. And I have apologizing to you once again. The speaker should not join before the moderator, actually. Join earlier. But I was in some engagement and I told Shivang and Secretariat to please convey that I'm taking 5-7 minutes. Sorry. So a quick warm welcome to our esteemed speaker of the evening, Dr. Parveen Jain, and to all the panelists and attendees. And I'm Dr. Pavan K. Gupta, part of AUHD, a Delhi branch of IUH, Indian Association of Occupational Health, as executive body member, and also joint web secretary for IUH, Indian Association of Occupational Health, and secretary for Haryana branch of IUH. So this is a quick and brief background about me, Dr. Jain, just to establish the familiarity. And we are so privileged to have you among us this fine evening. And these programs and these educative sessions definitely keep us all updated. And as you would be aware, this is a occupational health physicians body. Some 3,000 plus strong physicians are connected. And all these organizations as Maharatna, Navratna, and Mini Ratna companies who are driving India's economy. So the people, the healthcare service providers who are responsible for the health of these employees of these giant organizations, SAIL, BHEL, GAIL, ONGC, NTPC, and for that matter, private organizations as well, be it Reliance, be it Tata's, be it Adani's. So all these, these are the people who are keeping them healthy and also forming the backbone of the entire structure. So we are privileged to have you with us, and you'll be sharing your thoughts on, as you have already has been shared, that on regarding the screening of breast cancer, must to know. A very pertinent and important topic. I guess it is second most prevalent cancer still, if my data goes right, globally, probably. So it's 106th issue, Dr. Jain, and to all the panelists and attendees. Series 1, we are still running, and we have done this for so long, Dr. Jain, that it is 106th time that we are doing this webinar. We have our YouTube channel, our social media platforms where this is available. So even if there are less attendees and less panelists who are not able to join, because it goes to very wide audience. Today, if they are not able to join on time, they come back on the channel and they review and they view the entire session for their own benefit and for the knowledge. Yes, it's a global audience actually, Dr. Jain, which it goes to. So the numbers, if at all, at times what happens that people have their occupancies and they're not able to join on time, but then this is circulated amongst all occupational physicians of the country. And also, since it is the channels are there, so it goes to global. And we have that bank with us now. 106 webinar knowledge bank with us. So we'll be sharing that link with you as well, Dr. Jain. With those words, I will not take any more minute to introduce our esteemed speaker of the evening and then hand over this e-platform to him to take ahead the deliberation. So introduction to Dr. Jain. Dr. Parveen Jain is senior consultant and head of department, medical oncology, Akash Healthcare Super Specialty Hospital, New Delhi. Dr. Jain is working in the field of medical oncology since 7 years. He has a vast experience in the management of both hematological and non-hematological malignancies, breast, lung, GI malignancies, and other solid tumors. He has completed MBBS from KMC, Mangalore, DNB in general medicine from JGH, Rohini, New Delhi, DNB in medical oncology from RGCI and RC, New Delhi. He cleared European certified medical oncologist exam conducted by ESMO, that is ESMO, medical oncology in 2016. He has also done preceptorship in prostate cancer and lung cancer conducted by European Society of Medical Oncology in Singapore. Dr. Jain has keen interest in conducting clinical research, and he has participated as a co-investigator in various phase 2, 3, and 4 clinical trials. Dr. Jain also has numerous publications in his credit in various national and international journals. He is an active member of European Society of Medical Oncology, ESMO, Indian Society of Oncology, and he has done many oral and poster presentations in national conferences. That's some kind of achievement, Dr. Jain, and we applaud that, what you have achieved in so short span of time. And we are privileged, once again, I'm saying, to have you amongst us. This e-platform is all yours for the deliberation, and we look forward to gain the knowledge on screening of breast cancer, must to know. Thank you.
Thank you, Dr. Gupta. Thank you. So it was a very, very, very warm welcome. And I know, so your organization, it's a very huge organization, and you people are the backbone who are taking care of all the occupational hazards. And see, it's a different science altogether. So it's combination of the general science, what we practice. Along with that, there is a separate science. So when there are a lot of courses also which are coming for occupational and environmental health hazards. So hats off to you guys, first of all.
Thank you so much. We are privileged. Thank you.
Okay, so I'll share my screen.
Sure.
So I hope my screen is visible.
Quite visible, yes, please. Yeah.
1 second. Okay. Yeah. So today I'm not here to teach you anything. So I'm going to discuss a very, very pertinent topic. So that is breast cancer screening. So we know everybody is asking these days why the cancer is so much prevalent in India, in the rural populations also. So why the cases are increasing, what are the causes for that? So why the outcome in India is worse as compared to the Western population, and particularly about breast cancer. So it is the most common cancer in our females, and it is also, if you take both the sexes combined together, so worldwide, if you see, it is the most common cancer, both in terms of incidence and mortality. So it has got the maximum mortality related to cancer in both the sexes combined together. So this is the Globocan 2018. So Globocan is a cancer registry, which is a global cancer registry, and they analyze all sort of cancer patients, and then they release every yearly or 2 yearly the data. So what are the current statistics? So according to the 2018, breast cancer was the most common cancer in India in females and in both sex taken together. And if you see the Western literature, so there the breast cancer is so common that 1 out of 8 women, they will develop breast cancer in their lifetime. So that amounts to 12.5% risk of breast cancer in a lifetime in a female who is taking birth in the Western population. If you see Indian data, so it is 1 out of 22 women. So that means that we have slightly lesser percentage as compared to the Western world, and probably some of this is because of the poor screening guidelines which we follow. So we do not have very stringent screening guidelines to follow, and because of which probably our incidences they are less. We are not able to identify these breast cancers in minority, or you can say considerable amount of population. So in India, 1 out of 2 women who are diagnosed with breast cancer, they live for less than 5 years. So it's a kind of situation which we should deal with it on an urgent basis, because as compared to Western population, so we have all the facilities available in our country. The only thing is the awareness is lacking. So we as a clinician or as a general population, we are not aware of the breast cancer. So if you see in the Western population, So they have 12.5% risk of dying in less than 5 years time. So as compared to 50% of our women who are diagnosed with breast cancer, they die within 5 years. And the most common cause of this poor outcome, it is because of the late presentation. Most of our patients, they present in the late stages of the disease. So advanced stages like stage 3 or 4 cancer, and because of which they are not able to get the treatment at a appropriate time. And why this late presentation? It is because of the lack of breast cancer awareness, the prevalent prejudices that are females, they do not tell about the lesions in the breast, because it is something which is very private to them, and they do not disclose it to anyone. And about the alternative treatment also, in India we have a lot of alternative treatment. We have homeopath, we have Ayurveda. So I'm not saying they are not good. The only thing is, so there are certain scenarios where surgery is very important, where radiotherapy is very important, and where the cancer directed treatments are very important. So anything which leads to delay in these treatments, so that leads to progression of the tumor, metastasis to some other site, and finally they lead to a very poor outcome of the disease. So this is to introduce the topic, and this is the reason why we are discussing breast cancer screening today. And I've been discussing this topic in all type of forums to make the people aware of breast cancer screening guidelines. These are very simple investigations which we can do, and we can help the patient to identify the tumor at a very early stage. So we are going to discuss this topic in following headings. So first is who are the average risk females, who are the intermediate risk females, and who are the high risk females. Then about the screening modalities. So whether to use mammography, we have a lot of new forms of mammographies which are available. The lab people, they come to you that we have digital mammography, we have digital tomography, we have film mammography. So which one to choose? Then clinical breast examination, which is a very important tool in India or resource limited countries. Then self breast examination, then MRI of the breast, and then coming to the final topic of screening guidelines. So what are the guidelines for average risk, intermediate risk, and high risk? So we are going to dissect all these topics one by one. So coming to the breast cancer risk. So first of all, we have to know what are the risk factors for breast cancer. So there are a lot of risk factors for breast cancer. Some are modifiable, some are non-modifiable. The non-modifiable ones are the age of the patient. So it is a cancer which the incidence increases with the age. It is less common in less than 40 years of age. It is more common in more than 50 years of age. And 40 to 50 years is something which is an intermediate sort of age criteria. Apart from that, so there are other factors like obesity. Then apart from obesity, so there are some hormonal factors like early age of menarche or the late of age of menopause. So it is related to the estrogen's exposure. So more the estrogen exposure, more are the risk of breast cancer. So the age of menarche, if it is less, the age of menopause, if it is more, so that leads to more ovulatory cycles, more risk of breast cancer. Then a female who is nulliparous or who have the first childbirth at a later age, or where the number of pregnancies are less, so they again make the patient vulnerable for breast cancer. Apart from that, so there are some high risk factors. So like personal history of breast, ovarian, fallopian tubal cancers, or peritoneal cancer. So these are the high risk categories. Then family history of breast cancer, ovarian cancer, fallopian tube cancer, or peritoneal cancer. So these comes into the category of intermediate risk. Then there are certain ancestries like Ashkenazi Jewish. So they are associated with this BRCA1 and 2 mutation. So BRCA1 and 2, these are the genes which are implicated for most of the hereditary breast and ovarian cancer syndromes. There are other genes also, but these are the most common ones. So then a person who is a known carrier of pathogenic mutation for a hereditary breast and ovarian cancer syndrome in self or in a first degree relative, then the breast density, if mammographic breast density is high, so they again becomes a intermediate to high risk factor. Then previous breast biopsy. So a patient who had a previous breast biopsy which indicated a high risk lesion, not a cancerous lesion, but high risk of developing cancer at a later time, like atypical hyperplasia. So those kids or those females who had received radiotherapy to the chest wall between the age of 10 to 30 years. So radiotherapy, it leads to increase in development of second cancer in the radiation field. So whenever a female has received a chest wall radiotherapy at the age of 10 to 30 years, 8 to 10 years later, there are chances that the patient might get breast cancer. So the risk is not that high, but yes, on an annual basis, so the risk increases. And apart from these clinical factors, so there are certain risk prediction models also on the basis of which we classify the patients in these risk criterias, classifications. So first is the average risk classification. Average risk population are those who have the lifetime risk of developing breast cancer to the tune of less than 15%. So we had discussed in the initial slide that the average the risk of lifetime risk of development of breast cancer is to the tune of 12.5% in a normal female. So average risk are those who have the lifetime risk of less than 15% of development of breast cancer. Moderate risk are those who have the breast cancer risk of 15 to 20% in the lifetime. And who are these females? So these are those females who have a personal or family history of breast cancer in a first degree relative but do not have a known genetic syndrome. So they have family or personal history, but they do not have a known genetic syndrome. Then coming to the second criteria, which is the women with dense breast. So whenever you do a mammography, if it is a dense breast, so then again it assigns, these patients are assigned moderate risk categories. Then coming to the third, which is the history of high risk lesion. So which are ductal carcinoma in situ, then lobular carcinoma in situ, then atypical ductal hyperplasia and atypical lobular hyperplasia. So these are the four high risk lesions. And if at any point of time the female had a breast biopsy with these categories, so then she is assigned to a moderate risk category. So high risk are those who have hereditary breast or ovarian cancer vulnerability syndromes, or their first degree relative with such kind of mutations, and the history of chest wall radiotherapy between 10 to 30 years. So why is it important to risk classify the females? Because the screening guidelines and the risk of development of breast cancer, they are more, and the age at which the breast cancer will develop, they are also different. So like coming to this chest wall radiotherapy, these patients, they are prone for development of breast cancer 8 years to 10 years after receiving of radiotherapy. In the genetic risk syndromes, so the patient, the index case, at what age that index case was diagnosed. So 10 years prior to that, the screening has to be started, and these are the patients who are at risk at this particular age group. So like if a female is diagnosed with BRCA1 or 2 gene mutation at the age of 40 years and she developed breast cancer at 40 years, so her daughter, she will be advised to start screening at 30 years of age, 10 years earlier than the age at what she developed breast cancer. So coming to the next thing, that is the screening modalities. So mammography. So it is the gold standard for breast cancer screening. It is the best studied modality, and it is the only imaging modality which has shown breast cancer mortality reduction. And there was 20% relative risk reduction pertaining to breast cancer mortality. So coming to the initial times when we were doing film mammography is nothing. It is just an X-ray of breast. So the breast, they are compressed between the plates, and the X-ray is taken where the exposure has been taken up by the radio sensitive films. So this is the film mammography, but you are not able to set the resolution, and you are not able to look at a particular spot. So there are a lot of other imaging variations. In digital mammography, you are able to see those. So it is just like a camera. So here there are no films. The only thing is that I'm talking about the direct digital mammography. So here the breast is exposed, and the film is taken as a digital picture, and you can modify the picture. You can make it high resolution or low resolution. You can check at a particular point, and you can just focus on that, and you can increase the size of the focus also. So there are a lot of manipulations which you can do in the digital mammography. But the problems with film mammography or digital mammography is that they have a false negative rate of more than 30%. So false negative rate means that you have a lesion, but you are not able to detect with these particular investigations the lesion. So this sometimes happens in those patients who have dense breast. So what happens is that in a younger age group, when the glandular tissue in the breast is more, so the breast parenchyma appears to be dense in these radiographs, and you are not able to delineate the breast parenchyma from the lesion. So sometimes this happens. So this is called dense breast or dense parenchyma on the digital mammography. So these are the limitations of film mammography and digital mammography, that they have a high chances of missing out the lesion because of the dense breast. And to resolve these issues, so there are other modalities like MRI. So but it is not easily available, and MRI, the problem is that it has got a high false positive rate. So it tend to pick up those lesions, so which are not exactly looking like cancers, but because of the anxiety, you tend to do more biopsies, and more lesions, more biopsies. These are the limitations of MRI. So to solve these limitations, so digital breast tomosynthesis, so this came out in picture. So what happens is, in digital breast tomosynthesis, so digital mammography, it is a two-dimensional image, and it is a direct digital mammography where the picture is taken and you directly look at the film, the picture. So it is a direct imaging. So but in digital breast tomosynthesis, there is a machine which revolves around the breast in an arc, and it takes pictures at various degrees of angles, and then these pictures, these are taken up by the computer software, and they are reconstructed to make a 3D image. So here the chances of false negative is to the tune of less than 15%. So it has certain advantages over digital mammography. But yes, so digital breast tomosynthesis definitely has more radiation exposure as compared to digital mammography. So apart from this ultrasound breast, so it is usually not used as a standalone method for screening of breast cancer. But yes, it has a potential adjunctive role to mammography in women who have dense breast. So the final takeaway message is, so a patient who comes in a younger age group, less than 40 years of age, when wants to do a screening mammography, so only digital mammography is not going to solve the issue. So either you will have to combine digital mammography with ultrasound of the breast, or you can directly move forward to digital breast tomosynthesis. So this is the appropriate takeaway message. So coming to the next thing, so that is clinical breast examination. So clinical breast examination, it is a breast examination done by a healthcare worker who is trained to do so, and it acts as an adjunct to mammography in average risk categories. So in limited resource setting, like in our rural population or in India, where the city is not tier 1 cities, I'm talking about the tier 2 and tier 3 city where mammography, digital mammography is not easily available. So their clinical breast examination, it will have a greater screening role. So coming to breast self-examination, it is nothing but a patient, a lady will do the breast examination herself. She will stand in front of the mirror. She will have a look at the breast, the symmetry of the breast. Is there any lesion? Is there any redness or any protuberance on the breast? So apart from that, she will do the palpation of the breast also in all the quadrants of the breast, and along with that she will also she is also supposed to do the axillary palpation, and if any lesion is palpated, then they have to report it to the oncologist or their physician, and they will decide on the whether the patient will need mammography or the breast biopsy, depending on whatever the examination findings are. So this is the meta-analysis of breast cancer mortality after 13 years of follow-up in breast cancer screening trial. And they have taken almost all the breast cancer screening trials. And we can see over here that the hazard ratio in this meta-analysis was 0.8 in favor of screening mammography. And so it suggests that there is, so hazard ratio of 0.8 suggests that there is 20% relative risk reduction in terms of breast cancer mortality when the screening guidelines they are followed, when a screening mammography is done on an annual basis. So coming to the guidelines, so these ACR appropriateness criteria. So these are defined by American College of Radiology, and they have given rating to all sort of procedures, all sort of modalities, and according to these rating we can select out which are the modalities to be used for screening and which are not the modalities to be used for screening. So we can see over here. So for average risk women, we can see ultrasound breast. It has got a rating of 2. So the rating of 1 to 3 is should not be considered as a standalone modality. 7, 8, and 9, that means they should be considered. And 4, 5, 6, these are the modalities which can or cannot be considered depending on the uh, uh, depending on the risk of the patient. So we can see over here that for average risk women, so only mammography, it has got a rating of 7 to 9. So which suggests that in average risk women, mammography is the only modalities which has got the benefit and it should be used. And we can see the relative radiation exposure also. So MRI breast and ultrasound doesn't have any radiation exposure. However, mammography screening does have some radiation exposure, and it is not very high. So it is to the tune of 0.3 millisieverts, which is almost equivalent to 1 to 2 chest x-rays which we do. So if we see the high risk women, and we had seen the criteria for high risk women, so ultrasound breast is 6. So standalone, it should not be considered. But if we see these patient mammography screening 9, MRI breast without and with contrast 9. So what happens is that in high risk women's, not only mammography, it has to be combined with MRI of the breast, and both of these should be done together as per the age category which we are going to discuss next on an annual basis. So these are the other professional societies which recommend breast cancer screening at different time points. So most of the recommendations are to screen for breast cancer screening after the age of 50 years. But why American Cancer Society advocates it to be started at 40 years is because according to them, 40 to 50 is the age group where if you are able to pick up the breast cancer at early stage, so then you will add up to the life survival more in this particular age group, because 50 years the life expectancy will be less and 40 to 50 years it will be more. and it will be a productive life, and the people might be working, because of which you will not lose the quality times and your working times. So this is the reason why American Cancer Society, they have considered 40 years at the cutoff as the cutoff to go for the breast cancer screening. To sum it up, these are the guidelines. So ACS guideline for average risk women suggests that women age 40 years and older, they should get a mammogram every year, and they should continue to do so as long as they are in good health. And women in 20s and 30s, so they should have a clinical breast examination as a part of their regular health checkup by a health professionals every 3 years. And in breast self examination, it should be started at the age of 20 years. So regarding the intermediate risk women, so we do not have enough evidence to recommend for or against annual MRI screening. So at this point of time, it is shared decision making, and you have to proceed with annual mammography. But annual MRI, it is according to the discussion with the patient what you have. And these are the three risk factors which are considered in intermediate risk category. So one is the personal history of breast cancer, then a history of high risk lesions like DCIS, LCIS, atypical ductal hyperplasia and atypical lobular hyperplasia, and a dense breast parenchymal pattern. So coming to the high risk population. So high risk population, we know the definition: those who have BRCA1 or BRCA2 gene mutation, or those with a first degree or relative with a hereditary breast cancer, ovarian cancer syndrome, or women who had received radiotherapy, chest wall radiotherapy between 10 to 30 years of age. So these patients, they should be screened with an annual mammography and bilateral breast MRI on an annual basis, starting from 20 starting from 30 years of age. And in particular, those females who had a chest wall radiotherapy at a age less than 25 years of age, so they should be started 8 to 10 years after radiotherapy. The mammography, the screening mammography plus MR mammography should be started. And this should not be started below 25 years of age. It doesn't have any significant benefit in this particular age group. So if the woman is 25-year or older, annual screening mammography should be started at 40 years in the radiation category. But if the female is younger than 25-year, annual clinical breast examination is recommended starting 8 to 10 years following radiation therapy. So with this, I would like to end the topic, and the final slide is the BIRADS assessment categories. So you might have seen in many mammographies, so BIRADS 1, BIRADS 2, BIRADS 3. So what are these BIRADS? So BIRADS is breast information radiology and data softwares and data system. So in this, there are 7 categories. So category 0 to 6, and depending on whatever finding mammography is having, so there are risks of the likelihood of cancer in these particular categories. And we can see broadly, if you see, so category 1, it suggests that there are no findings in the mammography, and the category 1 is absolutely negative, no risk of cancer. Category 2 is that there is some finding, but it is benign looking. So essentially there are 0% chances of cancer in this. Category 3 is probably benign. So like fibroadenoma, some sort of fibroadenoma, they come in category of category 3, BIRADS 3. So in BIRADS 3, so there is less than 2% chances of developing cancer, of having a cancer. And these females should be these should be again these should be considered for a 6-month mammography scan again, to look for the tempo of the disease. So if it's a malignant lesion, the size will go up and the category might change from 3 to 4. and any shift of category, up shift of category, that gives indication towards malignancy. So category 4, it is a heterogeneous category, and it has got a high risk of 2 to 95%. So that is, it's a broad and heterogeneous category, and depending on the type of findings, so they are given the assignment to 4A, 4B, and 4C. So practically, whenever a category 4 or 5 is given in the BIRADS, so biopsy should be considered in these patients. And category 6 is those who have a biopsy proven malignancy. So these are the BIRADS category, and this is a universal system to report the mammography or the breast imaging. So be it mammography, be it ultrasound mammography, be it MR mammography. All these three modalities, they are given, they are reported according to the BIRAD system. With this, I would like to end the talk. And if there are any questions, I think we can take the questions right now.
Thank you so much, Dr. Jain, for that illustrative, comprehensive, very subtle, very elaborate, and at the same time, easily comprehensible. We really appreciate that. Because this is going to stay with us for very long on the digital platform, and it will be in our records. And I'm sure many of us would like to refer to it as and when needed. So we really appreciate that you spare your time this fine evening and share these details with us. But obvious that concern is definitely genuine and very obvious. 1 out of every 8 female, there's a mortality, and then 2 diagnosed in India. That's definitely a number. There's a very high mortality there. 1 survival challenges for 1 out of 2. Those are diagnosed, and I understand that this can only be controlled by early screening, early diagnosis, as that has been the thumb rule, and at various forums, this has been the sound. Yes. Early screening, as early as possible, and your emphasis on the entire categorization, classification, also the screening modality is quite elaborate, quite simple. I think this is going to help us very much. And about the good inputs on the false negative rate of more than 30%. That's definitely a good information. And also regarding the MRIs, where there are high false positives. So those are the really inputs which are going to, great inputs which are going to help us during the routine clinical evaluations, or for that matter, you have been part of clinical research as well. And those who are involved as the investigators or sub-investigators into the research, this is going to definitely help. ACR, you have elaborated very widely, which is going to help us. I have a couple of questions for sure. And then I will hand it over. I will check with our panelists and attendees if they have any questions. So one is definitely about the screening and early screening, early diagnosis. A lot of things are being done on the point of care part, POC. We keep hearing about it, but only an expert like you can throw some light that what is the relevance. Is there anything which has really come up, and people definitely can make the choice between the mammography or the ultrasound or the MRIs or that POC devices, or the developments have been there, and definitely other choice will be to go for the markers as early as possible. So these are my 2 quick questions. Would definitely like to learn more on this.
Yes, sir. So regarding the point of care devices, so yeah. In India, so there are organizations which have come up with a thermal camera. Yeah. So they are experimenting these thermal cameras, but we do not have any comparative studies as such. Okay. So they are doing it on a society levels, and they are trying to find out with a thermal camera whether there are any lesions in the breast or not. But ultimately, till the time we have validity of these approaches, so we will have to confirm the findings with the mammography. So at this point of time, so the mammography is the gold standard. There is no other modalities which are recommended even in the Western world or the resource limited settings. So the only thing apart from mammography, that is the clinical breast examination. But you will have to confirm any finding on clinical breast examination, on thermal cameras, on gamma cameras with a mammography. So
Okay.
we also were looking at the point of care devices because they become very easy. So
Yes.
you can take, so because you are not able to take the mammography machines to the societies, to
Correct.
the rural population. So
Ye-
with point of care devices, they will have this advantage that the scope of doing this test for a general population or for a representative population will be high. So you can take these. So just like an X-ray machine, you are not able to take the X-ray. So when the dots came, so
Yeah.
when this tuberculosis program came, so they started to do the mini X-rays. So
Yeah.
they established the sputum cytology labs or sputum AFB labs in the rural population. So this is a kind of thing which we definitely would like to have in our diagnostic armamentarium to so that we are able to detect the cancers at early stage, and we are able to do justifications to the patient.
Thank you so much
So,
for answering that widely. Yeah, please. You're saying something,
and
Dr.
the
Jan.
second question of yours was regarding the cancer markers.
Absolutely. Yeah.
As of now, we do not have any cancer marker for breast cancer. So
Okay.
we do have a CA 15.3, so which is available. So, but this marker is not at all validated. So we are also using this in basically those patients who have breast cancer to
Mhm.
monitor the response.
Okay.
So whenever we are giving any cancer directed therapy, so we do this CA 15.3 to
Okay.
see if there is decrement in this. So probably the patient is responding. So because we cannot do the scan every now and then, so
Mhm.
we are using this marker in this, and particularly in other scenarios like in a recurrent setting. So where the patient was diagnosed with breast cancer,
Mhm.
treated, and now the patient is under follow-up surveillance protocol. So
Okay.
there we are using this, but it is still not validated. No one can conclude
Sure.
that yeah, no one can be sure whether the high values, so they have some positive predictive value, or a low value they have some negative predictive value. So
Mhm.
any positivity has to be confirmed with a confirmatory imaging whether the
Mhm.
person is having a cancer or.
Thank you so much, Dr. Jan. That definitely clarifies. And the gold standard you mentioned is definitely mammography. But what about the pathology? Does CBC, definitely initial hints CBC gives, but is there any other blood test that you initially would recommend that, okay, for us from the screening perspective, this that also particular blood test also can give some hints?
So for
Any?
breast cancer, there are no blood tests as of now.
Okay, so it will be only depending upon the CBC report that there are some definitely highs and lows, and then connected to other. Uh,
No,
uh,
CBC has nothing to do with the breast cancer.
okay.
So
So,
breast cancer is that. So that is why I'm telling you that after 20 years of age,
yeah.
every female, they should be
Mm.
made aware of how to do self-examination of breast. So
Okay.
this will be the most effective tool, so that she will notice some abnormality in her breast, and then she can take her case to. So I am getting so nowadays people are like there is a there are three generations. So the middle generation, so
Mhm.
they are now aware of breast cancers. So they are coming to me that yes, I'm able to palpate a lump in my breast, can you just
Mm.
please examine it, can you just do something for it. And
Yeah.
most of the times they comes out to be fibroadenoma or
Yeah.
fibroadenosis. So
Mhm.
but they are well aware of this thing that it can be a cancer.
Yeah.
So this is something which is our duty to propagate the information, to propagate the awareness about the breast cancers.
No, no, all thanks to clinicians like you who have been definitely propagating this message, and that's why this awareness. For sure, this is you are the people behind this knowledge which has gone to the masses, and everybody is getting sensitive on it. I would immediately go to our esteemed panelist, Dr. Thagaraju. very patient, friendly, and he is one of the most esteemed panelists that we have had all the time. He would have attended all 106 webinars with us. Very dedicated and definitely our guide in terms of having a great knowledge bank. Dr. Tyagraju, please over to you for your thoughts, feedback, comments, and inputs.
Yeah. Good evening, sir.
Good evening, sir.
Okay. Thank you very much, sir. It's a wonderful lecture. Starting from your the most important, it's self-examination at the age of 20. I think by the 2030, there should not be any breast cancers. That should be our aim. And you have really explained very well. Mammography is the gold standard, as well as the ultrasound. And some of the things what you have said is cannot be taken to the villages. That is most important. And people will have a self-examination. And if they found some doubt, they can come to the taluka and they can get it in ultrasound or mammography. And if possible, get it corrected as early as possible. Very wonderful lecture, sir. It's really a gold standard lecture, and it is a benchmark and roadmap in the screening of the breast cancer for the young age up to age of 40. Thank you very much, sir. Very nice lecture we have heard. Thank you, Pawan. Very beautifully you have moderated and also asked wonderful questions. And your questions are really very good because we can learn more about that. Thank you very much.
That's your humbleness and gratitude, sir. That,
thank you. Thank you.
You are being very modest, and we are just trying to engage and just trying to bring this knowledge to our platforms, sir, so that we can propagate it more. All thanks to you for the continued guidance and engagement. We are learning a lot from you, how you are managing time for these webinars as well, despite having such a busy and hectic schedule that you have. So thank you so much, sir. Gratitude. I can see, Dr. Jain, that I have not received any question in my inbox and in my chat as well. So I have many more questions for which I will not hold the entire panelist and all the attendees here, and also will not prolong this webinar. What I will do, we'll get questions later on as well, Dr. Jain. So we'll route it through our secretariat or ourselves. We'll share it. We'll not bother you over the phone or as such. We'll mail you or maybe we'll text you, and we'll seek some answers from you in that times to come. Because people will definitely like to learn more with your experience and also the rich exposure that you have earned in very short time. So these are my final words, and on behalf of the organization AUSD, and also also the secretariat and the organizing body, I thank you for sparing your time today evening, and thanks to all the panelists and attendees for joining us. We definitely are going to engage tomorrow as well as scheduled. We will be having more sessions. Friday and Saturday are busy for us in the evening. We are trying to manage time, Dr. Jain, somehow. Yeah. Thank you so much.
So the pleasure was all mine.
Yes.
And it was a very good platform, and probably you guys also will help us in spreading the awareness about breast cancer, because you deal with hell lot of population. Right. So you are mainly dealing with all those PSUs and organizations, and you can definitely help us spreading the words.
All the giants moving the Indian economy.
Yes.
And then we are having our national conferences, Dr. Jain. Our secretariat will share the details with you for sure. We definitely would like to have you as one of the speakers in our national conference scheduled in Jan, Feb. 2 conferences are lined up, and Delhi has been fortunate to get in last 60-70 years is the 5th time that we'll be hosting that. It's a 70-year-old body, IOH, okay. And Delhi also has grown in last 20-25 years. It has been quite a lot of time that we have been trying to contribute. So we look forward to seeing you at the stage.
Definitely.
Thank you so much.
Thank you.